the reason we're here is obviously because of Truls' wife, actually. She was the one that instigated him to come up with the idea when they were pregnant with their first child. And as she's a diabetic since, 12?
Since she was told me.
And, so this was type 1?
Yes, exactly. And the complications during that period of pregnancy to actually monitor the glucose and inject the insulin during the night hours as the night nurse, he realized that, wait a minute, there's something that needs to be innovated here. And that's how he came up with the idea.
Yeah. Not formally a night nurse, though, but I took on the role as a night nurse, so making sure that she stayed level and everything went all right. My daughter is 13 years now, so it went well. And the company is almost the same age.
Oh, great.
And so the unique IP that Truls and his co-founder developed was the unification of the measurement of a blood biomarker and the injection of a liquid medicine or drug into one physical unit. That was the original patent. And around that, we've then built multiple patents so that we also can connect and log the data in a very specific way, which is unique. So we can actually measure the actually injected dose of insulin or medical drug, as well as monitor the wear of the device so that we can anticipate whether a device is about to fail. And then we added, as the first medical device, with an eSIM, so that we can have global roaming and be independent and secure from other devices when we communicate the data. So it's really a data play in the sense that the data that we collect from this device can then be shared with the stakeholders. So that can be a next of kin, it can be a nurse, a doctor, a science, but it can also be analyzed and processed so that we can move into a further process in the future about prevention using real life data to actually improve the quality of life of patients.
Yeah, so maybe you can drill down a little bit more on exactly what are the different components of the Actiste device, and what are they doing, what are they replacing,
Well, as a matter of fact, they're not really replacing anything. We're just making it a lot easier by unifying all of the components. So the blood glucose monitor, the test strip vial, the lancet, and the injection device are all into one single piece. And that reduces the number of steps that a diabetic has to perform each time they administer their insulin by 67%. So it's a huge user experience improvement. If you put, being a diabetic is not really a user experience, but we want to make it much easier to actually administer. So most of diabetics actually don't even bring their device along except for their insulin pen. And that obviously means that they don't really know exactly what amount of insulin they're supposed to be taking. And that means that they underdose their insulin, which leads to complications. And that is not a very comfortable thing to have, although it happens into the future. So that's a very important aspect of it, to bring along the glucose meter, which you don't forget because it's actually in the device. So you improve the probability that the patient is actually going to do their treatment recommendation according to the doctor's prescription.
Yeah, I would definitely think this would increase compliance. I know you're supposed to test yourself several times a day as a diabetic, and probably very low percentage do that. And it's to actually manage yourself properly, you do need. And most people are just giving some flat doses because it's easier. And then, as you said, they end up going hypoglycemic, which can be a major problem.
Yeah. I think that it's important. I mean, when you were doing this development, you really looked at sort of a medical Google perspective to collect data so that the data would be driving the improvement of the person's quality of life over time, so that you can actually do the prediction over time. But first you have to start with the actual basic treatment profile. So that's an important aspect of it all. But then you come into, with the real life data, you can start nudging, you can have intelligent feedback loops, coaching, that is really driven individually. So it comes down to somewhat of a precision medicine approach, although it's a chronic disease. So it's a very attractive solution going forward as well.
Yeah, so can you maybe go deeper into the service aspect, the benefit loop, and kind of all the information that provides to like family members and.
Exactly. Well, Jules, you're the
from a family guy's perspective, it's the whole business of managing diabetes is not just injecting yourself or testing yourself. It's remembering if you tested, remembering what dose you did, all the data collection there. But then you add the layer of prescriptions. You have to restock all your supplies. Usually it falls on next of kin. Hello there, that's me. So then I need to refill. I need to call the nurse to get the refill, go out and get the things. Lot of hassle. And also from the healthcare professional side, this is a large part of their workload, not perhaps the doctors, but the nurses. They tend to spend way too much time just handling prescriptions instead of giving relevant advice to the patients. So the holistic view on all the parts, making sure that you not only get the right device, you also will be restocked, resupplied, because that's inside our service. So you have the restocking of the consumables, which means that me as a next of kin, thank you, don't have to do the hunt down all the prescriptions. I don't have to run out to pharmacy to find where the heck are the compatible parts. Not there. I have to go to that pharmacy. I don't have to do that. It comes home because the system, the benefit loop, actually also keeps track of each and every user's inventory, so to speak. So when in due time, we just restock. So you don't have to do anything, you don't have to push any buttons, it just restocks. And then, of course, that data is valuable for me, but perhaps the most important data for me as a next of kin is, did you miss a dose? Then something, or you have value that's way out of range, that's an alert to me. And this is not just for type 1s, it's type 2s, many of them are elderly. Memory problems. Did I take a double dose? That can be lethal. So that's something you really want to avoid. Here, you can get an alert if you do a double dose, but perhaps most importantly, have been dosed for 24 hours. Something says up. The healthcare professional does perhaps want to monitor your parents, but you, I guess, wouldn't be interested in making sure that they get the right treatment. So then you, by our system, the benefit loop, you will be able to monitor them if they allow. So it's not that we invade their privacy like some companies tend to do, but we keep the data strictly in the end user's power, so to speak. They own the data, they control who they share it with. So
yeah, and I know this data is actually very powerful. Something happened actually this weekend with Dexcom. Has a continuous glucose monitor system, and they also have like alerts that they send, and that went down, and they didn't notify their users, and that became a very big problem with parents trying to monitor their kids remotely. And so it just showed all first that people were using that sort of service as an information service, and B, that it was very important.
No, and this is a very interesting analogy when it comes to Dexcom, because obviously there is a population within the diabetes community that has the need for very advanced services, such as the Dexcom or Medtronic or whatever. But it's really just less than 1% of the overall diabetes community. And there's really nothing beyond that. And that's where the Actiste service comes in. We can actually cover the rest of the insulin-treated diabetes community, which is quite a big portion, because roughly 40% of all diabetics are insulin-treated, whether from one shot a day up until multiple shot a days. So it's really a very important aspect to be able to provide a modern, state-of-the-art, connected service for those patients as well, at a very affordable price.
Yeah, and maybe you could discuss the pricing and how that might compare versus kind of what people are paying now for just glucose monitoring and insulin injections, and then the whole continuous glucose monitor.
Exactly. So I mean, if you would say that, I mean, I'll take the Swedish example. I don't really know the American example, as we're in New York now, so it's I can't compare that. But I think it's important.
You can double 10 times roughly.
Probably pretty close.
So in Sweden, you would say you probably pay $4,000 just to get a pump.
Yeah.
And then you get another 4,000 for the CGM, and then all of the consumables and everything there. So you add up around $10,000 a year.
Yeah.
Whereas for a normal glucose monitor, injection pen, and lancets and how do you say, the test strips, you're at roughly $50, $60, $70 depending on the solution that you're getting
per month.
And that's where we said that's where we're going to be. So we have basically said we're offering a superior solution which improves the life of the patients and also their next of kin in healthcare, but we're not charging for that additional solution because it's important to get the volume out there. It's important to penetrate into the market. And then we adopted a universal pricing model in the sense that we will adapt the pricing to the market's payment or willingness to pay.
Not 10 times off for the US.
No, we won't do that. So we'll take roughly what they're paying for the lesser solutions, and we'll charge the same amount of money for that. And then in countries where they don't really have that much money, but they have a ramping or even epidemic growth rate of diabetes, we will charge less, so that we can get the volume out there, so that we can process the data and come back with even further improvements into the service and the quality of life of the patients.
Great. And maybe you can talk about the, so what is your commercialization plan? You recently got 2 CE marks at the same time, which is very impressive.
That's right.
And you're going to be focusing on initially the UAE, Sweden, and Southeast Asian countries.
That's right.
So maybe just walk us through kind of your near-term plans.
I mean, we had obviously a selection of, we're Swedish. Why don't we use the Swedish market? The diabetes care is very good in Sweden. But we also have a very interesting administrative structure that goes back 400 years. So we have 21 independent regions with independent procurement processes. And we're not a very large nation. We have less than 10 million, around 10 million people. So the cost of acquisition of a customer becomes very expensive. And it's also a very competitive market. So we saw that we will obviously be in Sweden. We will sell our services to the Swedish market. But if we really want to make an impact, we really want to go into the markets that really need us. So in the Middle East, with 25% prevalence of diabetes and still growing in some countries. And then Southeast Asia, where you're not at those prevalence rates yet, but you have a ramping increase. So over 10% growth rate in some countries on the diabetes volume. And the volumes are big. So when we started thinking about where are we going and why are we going there, we started by first looking at the regulatory fit, which countries actually follow the European regulatory framework. And so both Middle East accepted and the Southeast Asian markets in the ASEAN community, they basically have adopted the European medical regulation or medtech regulations. And that's how we decided on that first level. The second level is the absolute volume of diabetes patients. And all of these countries have relatively high absolute numbers because they're large countries. Not the UAE specifically, but there's another aspect there is that they only have basically 3 buyers on the large scale in terms of the Ministry of Health, the Dubai Health Authority, and the Department of Health in Abu Dhabi. So we cover basically the whole country in 3 players. Obviously, you have the private market as well, which is important. And then you look at the growth rate. Europe, the US, growth rate 1% per year, roughly. So that's not relevant. Whereas in the UAE and the Middle East and Southeast Asia, you have at least plus 5% in most markets, and in some cases beyond 10% growth rates per year. So that's an important aspect as well. And then that you have a payment or payer structure, preferably a national healthcare insurance that actually also covers diabetes. But also in the case of, for example, UAE, you have a mandatory diabetes healthcare insurance, even in the private insurance market. So that's really moving forward, and many insurers now are looking to see the benefits of actually covering and not, kicking out chronics, because they see that by improving their status in health, they can actually be a relevant customer and a loyal customer. They get a good service. So it's very interesting from that perspective.
And what will be the timelines to expand to the EU5 countries, North America? So maybe now you can talk about what are your plans for expansion to the EU5, to North America? What sorts of timelines are we talking about?
EU5, are basically Sweden on a large scale. Unfortunately, they are rather fragmented, not as bad as Sweden, but they are interesting. But as Henrik said before, they fit the criteria of regulatory fit. They have rather large absolute numbers, growth rate not that, and but they have the payer structure there. So yes, we're looking into them, but they're not our highest priority.
I would say within the European community, Germany probably is the country that has the they've taken a leap now into digital health, which actually we didn't expect to see, but they've actually moved forward. They're moving into that direction. But they are also independent states. It's a federal country.
Mm-hmm. And then for North America?
North America, then we have the FDA question, the big question there. And our plan is to start the process rather shortly, but we haven't set the date. We see America is really interested, North America is really interested in the market. US is a bit complex, it's not one unified market, so to speak, which
it's 50 markets.
It's so we're looking into we see that partnerships is a good way of entering this market. So evaluating different options, and yeah, that's
on the 510K. On the actually getting approval front.
Yeah.
Do you think you'll just need a 510K clearance? Would it be a 510K de novo?
We think it's a 510K, but the de novo question is still up in there, I would say. But from our experience, it should be 510K, but let's see.
Because you have predicate devices that you can refer to, and then you're just sort of combining them. So. Yeah. I guess maybe just the benefit loop aspect might be the de novo.
Even there, you can see that some of the players who are on the market, but with single devices or single function devices, are actually in the digital space as well. Yeah. So, but it's the unification, obviously, that may put it in.
So you might need two approvals here, two clearances here, like in Europe.
Yeah, I would say that actually when it comes to the digital part, the FDA is a bit ahead of the European. It's easier to get approved in that sense than it will be in the EU. After the end of May, we're changing regulations in the EU, which is a big hurdle for European markets. But that goes for all new upstarts when it comes to apps and things like that. Then you have big issues. But we're confident that we're home safe there.
I mean, one of our key parts in developing the benefit loop, as Joe said before, is the privacy aspect of it all. The concept of our company is to have an impact on the individual life, and therefore the private ownership of the data is one of the key aspects. So cybersecurity is obviously something that we've focused a lot on, and this is something that the US market has been much better at preparing for and working with in the regulatory processes. So I think from that sense, it's a good market to be in as well.
Great. So, so what milestones should investors be looking for over the next 6 to 12 months?
Well, I think that the first milestone that we've announced that we're going to do is start the pilot in the UAE. And the reason we do the pilots is to really make sure that, in particular, the digital part is adapted to the local culture, the local way of interacting with apps. So that's part of the purpose of the pilots, if you put it that way. But then it's a major rollout in that region. Generally speaking, not only the UAE, but the wider region. So you have Saudi Arabia, you have Bahrain, you have Oman, and Kuwait as well. Obviously, Qatar is a different story based on the politics of the region, but it's an important region for us. And the regulatory processes there are actually swifter than in Southeast Asia. So Southeast Asia is obviously an important market from a volume perspective, but it's going to take a little bit longer to actually get the devices out on the market and the service out on the market, because the registration of the CE certificates will take longer than in the Middle East. So we've already established ourselves there. We have 2 agreements with mobile operators, which are part of our go-to-market partner structure. And we have people on the ground to sort of do that work with us. So we see that as being the second phase of that process. So during next year, I would say, without giving any forecasts or anything like that, I think it's fair to say that the UAE is going to be very important. Sweden is, of course. And I think from a Swedish perspective, we recently announced that we actually invested in a digital doctor company called Acumbo. And that's something that we see is important for the Swedish market based on the payer structure. And diabetics, I would say, are probably one of the really special groups that can benefit from it, because they have to, they typically don't meet their nurses and doctors very often, and they also have to go and meet the doctors and nurses, but they don't really need to from a treatment perspective. So the digital healthcare perspective is a very interesting one, the telemedicine perspective. But we also see that this investment in Acumbo is something that we can actually roll out on a global scale. Because in many countries, such as Indonesia, there's a lack of actual physicians to support the millions of diabetes patients. I think there's only 65 endocrinologists in all of Indonesia.
Wow.
There's roughly 2,000 internal medicine doctors, and those are the only ones that can actually prescribe insulin the first time around. And the GPs, which are roughly 100,000, it's still 270 million people that live there, that can actually, they can only prescribe pills for the first time, but they can re-prescribe insulin once it has actually been prescribed from a licensed doctor. So there, I think digital health is going to make a huge impact.
I think it actually would make a huge impact anywhere. I mean, even in the United States, where we do have plenty of doctors. Yeah. I mean, for an endocrinologist, a new point, it could take several months. Yeah. To get in, and otherwise you're managed by a general practitioner who's not really up to the task in most cases for managing anything related to diabetes.
And I think if we can get into that aspect, I think one of the biggest challenges that the societies have, whether it's a privately funded structure or a publicly funded structure, is that focus has been on treating the sick and the acute sick. I mean, it comes from the old war surgeons' historical background, but so type 2 diabetes has really not been in the focus enough, and people have not realized that in the whole life cycle cost structure of a diabetes patient, particularly type 2, is that we're not investing enough in the primary treatment of the disease, which leads to severe complications. And 90% of the life cycle cost of a diabetes patient is actually complications related to a lack of adherence and compliance to the actual primary treatment. And by improving the adherence, which we believe that our service will do, we can reduce the overall life cycle cost of the patient.
Yeah, I have a family member who has type 2 diabetes, and she was very poorly controlled, and
she's waiting for the Actiste.
Exactly. She's actually in the Middle East. she started off with just obviously diabetes, but then got 6 other different conditions that stemmed from the diabetes, and it's like the number of medications and everything obviously grew quite large.
It's a large problem, so it's multiplying with all the co-symptoms that you will end up with. So unfortunately, I think a combo deal that we've made is a really good stepping stone for actually expanding into those areas.
Yeah, no, I agree. I mean, I think making it easier is really the primary way to improve compliance. I mean, even like the continuous glucose monitor, you think that's easy, but it's not really, because they can only be used for a week at a time. They sometimes scab over. There's you have to pick different spots all the time. So they're a little complicated as well, obviously.
Or you get an allergic reaction, so you can't have them. You need to choose a different brand that doesn't work for you, and so forth. There is no perfect solution. So
So anyway, just want to thank you for joining us.
Thank you for having us.
It was a great conversation.